Check ma'am. Go check ma'am.
Hi everybody, welcome and thank you for coming. My name is Sylvia and I'm a soon-to-be graduate of School of Human Development this Saturday. I just want to take a short amount of time to thank Robin, who got me through my thesis whole process, and to thank him for the invitation for being here today. We'll jump right into my title. It is agoraphobia, not a life sentence. Just out of curiosity, and I don't want my family to respond, how many of you know what agoraphobia is? Oh, so a good amount of you do. Hopefully some of you don't. I wanted to enlighten you. Okay, you kind of know? Okay, I'm just going to talk to you.
I'm not sure if I do or not.
I'll ask you later if you were right.
Okay.
So I'm going to jump into the definition. Agoraphobia is defined by medicinenet.com as an abnormal or persistent fear of public places or open areas, especially those from which could be difficult or in which help may not be immediately accessible. That's agoraphobia. That definition doesn't really give you a really comprehensive understanding of what an agoraphobic person has to live through on a daily basis. So it just kind of gives you the fancy schmancy definition. The next slide is a short video clip, and what that video clip is, in hopes this was for me to get all of you to understand the true intensity of it. It's from a 1995 movie called Copycat. In Copycat, the woman in there was agoraphobic. She put a man behind bars. She's a forensic psychiatrist. And that man wants to kill her. That's all that he wants. She's agoraphobic. He is in her home. And she has two choices. Her first choice is to get out. And her second choice is to fight. So this is going to give you an understanding of exactly what an agoraphobic person's mind looks like. So she went back in. An agoraphobic, in her mind, she stood a better chance of going back in and fighting an armed serial killer than running. What you couldn't see in the clip is just downstairs there was an armed security guard that was paid to be at her front door, but he was helping a man with her car. A woman with her car, her alarm had gone off. Rather than run, she just went back in and fought. And when I saw this movie, this was in '95, this was after my diagnosis, it hit me. And I was hoping people saw it so that they understood exactly what goes on in our minds. Go to the next slide. Brings me to my personal statement. I was diagnosed at 15 years of age with agoraphobia. My story is, it was a very difficult journey because back then, when I aged myself, there was no internet. So I was 15, that was quite a long time ago. Without the internet, you can't just Google, symptoms. You can't, there's no direction, there's no one to help you. And especially with my types of symptoms, you can't go to a physical doctor, you don't know what to do. So my parents, and my mom in particular, had a very, very tough journey trying to find a way to understand exactly what it was I was going through. My symptoms they started from little. My mom always told me I was just a little different. I asked a lot of questions. Even when we were going to Disneyland or somewhere where I should be happy or excited, I would say, well, how far away am I going on the freeway? Is there a bathroom? Are there a lot of people? Those were always concerns that preoccupied my mind from as long as I can remember. Sitting still was very difficult. Being in a format right now where everybody's looking at me is extremely difficult because the symptoms of agoraphobia don't ever leave you. You just learn how to cope. So I've been coping my whole way up here. So I'm still coping right now, but I'm doing good. The symptoms intensified when I turned 17 and I started my junior year. I went one day, I left, I did not return. And it was difficult. So we ended up finding a therapist, and she was awesome and wonderful and amazing. And she got me through it. So I will talk more about treatments when I get to analysis, but this is just a touch of my personal statement. My methodology. I found 6 participants, and the way I found my participants, social media. I went on Facebook. They have agoraphobia and isolation websites with support groups with thousands of people, patients, just searching and looking for help. I did one email explaining who I am and what I needed, and that I was a former sufferer, because I thought that that was going to make them feel like I was, part of them. I wasn't an outsider trying to study them. I was one of them. Within, I'd say a couple of hours, I had over 50, like 55, 56 emails from people, and all of them saying the same thing. They all said, you can use my story, you can tell anything you want about me, just please tell me how you got over it. So it was difficult. So my goal was to find 3 recovered and 3 homebound individuals, which I did. The 3 recovered were 2 male, 1 female, and 3 homebound were 1 male, 2 females. So those were my participants. Data and analysis. What I did was I combined the information from my related lit section, and then I combined it with the participants' interviews. Who really suffers was my first topic. Related lit said that women primarily suffer. When Robin and I were looking at some of the articles out there, they're very, very dated, very dated. Unfortunately, there's not a lot of modern research done on agoraphobia. So when I did my research and my interviews, what I found is that they suffer equally. When women suffered more was in the days when women were housewives, when they didn't work, when they were raising children. Now, times have really changed. Now we have men at home. People work out of their homes, so they don't ever leave. Men raise children now. So it's a totally different society. And then the societal expectations of men are different. So men are suffering the same as women. There really isn't much of a discrepancy that I found. When I went on the websites and when I looked at the people that were emailing me, I saw a 50-50, not exactly, but a good split amongst male and females. Another interesting thing I found was age of onset. That was really cool. My 3 recovered participants were all diagnosed at 14. My 3 individuals that are still homebound currently were diagnosed in their 20s and 30s. So we looked at that. I looked at that. And I always would use myself because I was diagnosed as a teen. And I knew what my motivation was and what their motivation was. And when I interviewed them, it came out the same. They didn't have the complexities of the world around them. And they weren't really tarnished by some of the expectation, what society says that mental illness is. They just wanted to get better. That's all they did. They wanted to get better. They wanted to go to the prom. They wanted to be with their friends in high school and go to grad night. That was it, and that was what I wanted. I just wanted to be normal again. I didn't have children. I didn't have bills. I was not preoccupied with anything that an adult would. So those people, and you just have, I had a naive mindset at the time, and I don't know about theirs, but mine was. And I figure I'm sick, I go to a doctor, or my mind's sick, I go to a therapist, and they're going to fix me. And I had complete confidence in what I was doing and what they were doing for me. Those 3 individuals we say healed. They'll never be completely healed. It's like I said, our symptoms stay for life. They don't ever go away. We just learn to cope, and that's what we've done. So for the individuals that are still homebound, they were diagnosed mid-20s through mid-30s, and they're still having a very, very hard time getting out. Only one, I think, gets out very, very infrequently, but it's because he lives alone and it's survival. He's got to eat. He's got to go out and go to the market. He has to buy certain things. And oddly enough, he's my most ill participant, and he named my thesis. He's the one who told me in his interview. He has multiple psychiatric diagnoses. He has a 3 split personality disorder. And he told me agoraphobia is not a life sentence. And I thought I would hear something like that from one of the participants that's recovered, and I didn't. I heard it from him. So it was amazing to see how hopeful he was. And he's battling, but I keep in contact with him, and I'm hoping you know, that I'm going to send in my whole thesis. Read it, and I hope it helps you. Second one was agoraphobia and anxiety. The literature states that they don't always work in unison. That you may have agoraphobia and not anxiety. You may have anxiety but not agoraphobia. That's true. You can have anxiety disorder but not have agoraphobia. But on the flip side, and through my research and through all 6 of my participants, through my own story, they exist together. Agoraphobia is the phobia, it's the disease, it's the illness. Anxiety is a symptom. Okay? When we're afraid to leave our houses, it's because the anxiety is coming. We're afraid of the anxiety. You know, if it could be in a physical form and we could see it, I can imagine it'd be far worse than seeing a serial killer wanting to kill you. You know, it's far, far worse. So, in my eyes and in my participants' eyes, when you step out, you're doing this. You're waiting for it to come. It is anxiety. So, there was not one of them that said that they do not exist in unison. Their onset is in unison. When you start to feel the fear to go out, you fear the fear of the anxiety is also there. So they always, usually from what I found, they're diagnosed together. You're diagnosed with agoraphobia and panic disorder. So my research was a little bit different than what the research in the books stated. Obstacles to diagnosis. These individuals have a very hard time being diagnosed. First off, when you become homebound, it's almost instantaneous. You deal with the symptoms as long as you can, but once they overwhelm you, you're literally, I was homebound from one day to the next. I was at my junior year in calculus. I told them I was sick. I walked out and I went home. I did not come back. I was homebound from that day on. So these individuals that are homebound, how are they going to get to a doctor? You know, we researched some media, and I'll speak about that, how that can help, but it's scarce. It's scarce and it's very sad. Also, misdiagnosis is very important. As people start to feel these symptoms and they go to the doctors, a lot of times they mirror maybe cardiovascular symptoms or, you know, stomach troubles. They'll say I have a stomach ache, or I have my heart's racing and I have asthma, I can't breathe. So they all can be diagnosed as something physical and get treated for something physical, but in the meantime, those symptoms are not getting better, they're getting far worse, and that's bringing, you know, the homebound part a lot closer to them. So misdiagnosis is a big deal for them. Also insurance. For individuals that are homebound, they can't work and they can't get insurance, they're uninsured. The only person, my participants were minors, the 3 that were diagnosed early, so they had the insurance benefits of the parents. But for the adult ones, 2, I believe, were single, and they're heavily relying upon state insurance. And what's happening with that is even physical conditions are ignored, you know, so imagine the mental ones. The psychiatric care for them is extremely limited. You're not going to have a psychiatrist leave and go to your home and sit with you and walk you through the therapy process. It just doesn't happen. So medical insurance is a very big obstacle. As far as media, that's the last one, and that's how we reach the homebound. I wrote in the last section of mine, Dr. Phil has Doctor on Demand. I don't know if you've heard of that. What Doctor on Demand does is use your cell phone, and you're able to come in contact with physicians and therapists that can help you. Now, the price is like the most unreasonable. I think it's like 20 minutes for $50. And I can tell you from experience, my therapy sessions, if they were 20 minutes, it would not have been, you know, they wouldn't have helped. And I think 50 minutes was $130, $40. So who can realistically afford that, you know? And when I looked up the list of psychiatric things that they treat, agoraphobia was not on the list. There were more common things like anxiety disorders, eating disorder, bipolar disorder, things like that. No agoraphobia. They even had a list where they said we will not treat these disorders, and it wasn't even on there. So these poor people are completely invisible, completely. The media is such a useful tool. We use it for so many wonderful things. And now we have, you know, Skype and FaceTime. If your family's across the world, you can talk to them. I just have a hard time wondering why therapists that know about this disease, and especially seeing the amounts of people that are looking for help, it's out there. Somebody has to know about it. Why they would be, not all are unwilling, I'm sure, but why a good portion of them are unwilling. You get paid the same. You can file an insurance claim, just do it on a computer. You know they're going to be on time. You know, they're there. You don't have to worry about a lot of different things, and I don't understand why that's not a bigger part of the diagnosing and treatment process, you know, of an agoraphobic person. Oh, I skipped treatments. go back to treatments. CBT is cognitive behavior therapy, and that's pretty much the most commonly used form of treatment, but it's also accompanied with exposure therapy and skill training. I'll go into that. CBT works to help retrain the mind. An agoraphobic person and mindset is it's not like a normal mind. Everything is heightened, our thoughts become heightened, our fears are irrational and abnormal, and you know that, but the thing is you can't fight it. It's real to you. So CBT works to help. You do a lot of repetitive practices in it. You literally have to retrain your mind. It's like a habit. You're making a habit of going out, and you're making a habit of seeing that nothing's happening to you. And in doing that, you're de-escalating the fears. So in vivo exposure therapy, in vivo and interoceptive exposure therapy, there are two different types of exposure. So basically what they do in exposure therapy is they're exposing you to things that they know are going to incite the phobia and the anxiety. That's why even treatment for me was very, very difficult. I didn't want to go because I know when I went, I was going to be suffering. You know, who wants to go? If you know you're going to go somewhere and be in pain, are you going to go? Of course not. So it was a fight. It was a fight to get me to therapy, you know, once, twice a week, because I knew when I got there, she was gonna do something to me, make me do something. It was very difficult. In vivo is in a not controlled environment. In vivo is done outside. I didn't practice in vivo therapy. It is, I can't leave my front door. So they say you take 10 steps out of your front door the first day. Second day, you take 20 steps out of your front door. Next day, 30 steps, and so on and so forth. And then they'll say, you could do it with a partner. Second day, you take those 20 steps, but your partner remains 10 steps back. Third day, you take your 30 steps, your partner goes further back. Teaching you to be self-reliant, you have to. It's not easy though. So that's in vivo, and it is a very long, drawn-out, and tedious process. You don't see results right away, and that's where I think people get frustrated because you want some relief. You feel like you're going to die. If you step out, you're going to die. It's going to get you, and there's no relief. Every day is a constant battle and a constant reminder that it's coming back. Interoceptive therapy is done in a controlled environment, and what she did to me, because I told her I get dizzy and I feel like I'm gonna faint and I can't breathe and I hyperventilate, and you know, I was telling her all my symptoms, and she had the kindest, softest voice in the world. You can hear her stuff, and she would say, Sylvia, you know, that's not gonna happen. And I was not the best patient. You be quiet, are you agoraphobic? No. You know, you don't know that it's not gonna happen. You gotta understand, you're not crazy like me. And if I could find her today, I would apologize for some of my behaviors. I was a little feisty, but so what she did was she stuck me in her chair. She had one of those big, you can imagine in a therapist's office, those big cushy chairs. Put me in that big cushy chair, and she spun the heck out of me. And I mean, my legs were like this, and she spun and spun and spun. And I was like, stop! So finally she stopped me, and she goes, stand up. And I was doing this. And she's like, watch, you're not gonna faint. And I'm like, yes, I am. And her went in circles, and I did it. And she told me, sit down. I'm like, what next? You know, goodness. She said, hyperventilate on purpose. So, for 2 minutes. It doesn't sound like a long time, but literally everything numbed. My fingertips numbed. Everything started to go woozy. And she goes, okay, stop. You're not going to faint. And I said, okay. And I waited because I kind of wanted to prove her wrong. And I did it, and I was like, dang it, maybe she's right. So it's those kind of practices that really help retrain the mind, that you think when it's coming in, you're out in public, you think, I'm never going to spin that fast in my one unless you're on the teacups. I'm never going to spin that fast. So I won't faint. Or, you know, I'm never going to breathe like that ever. So maybe I won't, you know, I'm not going to pass out. It worked. In addition to the exposure therapy, they do skill training. Skill training is teaching you, like progressive muscular relaxation is a skill training. And you can do it when you're out at dinner, nobody will know. You tighten your muscles, very, very tight. You count to like 10, and then you release them. You release whatever you're tightening, your feet, your hands, your arms, and you really focus on that relaxation. And you can do it throughout your body, and people won't know that you're doing it. I was taught that in therapy, and I used that through the duration of my process. Where am I going? In my notes. Also, they teach deep breathing exercises, you know, where it's 4 by 4, you breathe in 4, you breathe out 4. Just to kind of regulate. That didn't always work for me, you know, because I'm trying to count by 4, it just didn't work. But the progressive muscular relaxation did work, and the breathing works for some people, you know, so all those things in combination, you know, were magic. Medication was, I had a mixed finding. In my story, I went without medication for like a year now, about a year. And when it got to where I was in a room. I wasn't even in my home. You know, I was in one room. So when that happened, they said, okay, we're gonna try medication. So tried a lot. Oh Lord, some have you sedated to where you can't get up. You know, it was awful. But I found my combo. And I used that for, I want to say about 6 months to help me get out. And then I stopped. And I haven't taken it in, oh Lord, 15 years. So to me, that's an accomplishment. It is. So my participants, I actually had 2 that did the same thing. 2 of the 14-year-olds that were diagnosed, the parents were against it. You know, you have a child. You don't put them on psychiatric meds. They're babies. But they needed it. They needed it. Unfortunately, the other participant had one turn to alcohol and drugs because he didn't have the family support. He didn't know what was going on. He felt like he was going crazy. Went to alcohol, which added a whole other facet to his recovery. He was now an alcoholic. He's addicted to drugs. He was a phobic with panic disorder. And he's one of the ones that recovered, so that was good for him. And I have 2 left. One does like a holistic type of medication where she does like these vitamin supplements. And she's taking very, very, very high doses of magnesium. So, you know, I told her just look into that and see if there's any type of, I don't know, but, you know, vitamins in excess can be dangerous. Look into it. If it's working, you know, I'm glad for you. The other one does no medication at all, and one is addicted to Xanax. He's on 6 milligrams a day. And I think at my height, I was at 1. I do half a milligram and half a milligram. That was when it was so extreme that I couldn't take it. And just like in the video, the reason why I wanted to show you that was because that really happens. When you're leaving and her vision got like this, that is exactly the way it happens. That's exactly the way your eyes see. They see everything turns this monotone color and things start to sway. And it's the scariest thing you can imagine. So, you know, in the height of my disorder, I would have made the same choice as she did. Because you just think, I'll fight till I die, but I'm gonna do it. I'll stand a better chance. So, you know, the medication was a very useful tool. And it's used as a crutch. And that's what a lot of them used it. They use it as a crutch. But without the combination of true therapy, cognitive therapy, you're going to become dependent. And because you feel a little bit of relief, and so more and more and more. And now that patient he cannot get off of his Xanax. He's hooked, and he's going from doctor to doctor to doctor. And unfortunately, they're feeding his habit. He's not telling them that he's seen multiple psychiatrists, and he's getting now on more Xanax than that. But he said, I need to eat, I need to get out, and it's the only way I can do it. So it works for some, it's productive for some, and it's dangerous for others. It's a very, very difficult thing to experience. So those were the 5 points of my data analysis and my related lit. And my significance. When they talked to us about what's important to you, this was instant for me. I knew exactly what was important to me and what I wanted to learn more of. I know the disorder because I lived it, but I have a lot of unanswered questions. How did it get me, and why are people suffering with this? It's such an obscure and awkward thing to go through this. And even me looking back now, I kind of don't believe it. It's like, why didn't I just get out? You know, I couldn't. So I picked this. I wanted to quote myself. I thought it was pretty cool. That's me. My quote that displays my significance was, it's an individual that is homebound has lost their voice to a disorder that has consumed them. The thesis will become their voice. It will help redefine agoraphobic individuals as ill and not insane, as visible and not invisible. These people are invisible. They're completely invisible. And if you were to see us out there when I was ill trying to get better, you would think we were insane. We look different. We're talking to ourselves because you're taught self-talk. You're taught to try to focus on something. That's why you couldn't hear her, but she was naming the presidents. That's what she was doing. She was going from 1 to 2, 3, 4, and that wouldn't help me. I don't know the presidents, but I did different things anything where you have to focus on something, that's what she was doing. And, you know, we would look awkward, we would look different. To have to face that is so embarrassing, so difficult. So they choose to stay invisible, at least they're not hurt. You know, and they're certainly not insane, they're very, very ill. And I think lost my voice when I was ill, and I lost it by my choice. I gave up. I gave up. And, you know, because I had the family that I had, they didn't let me. So, you know, they were my voice in that process. And hopefully if anyone reads this, I can help be someone's voice, or I can help those participants that so willingly lend me their voices to, somebody can read it and they can know that they're speaking to someone. That was my goal. That was significant to me. Conclusion. It's always a good thing to see. An important thing for me in doing this was that there's such a negative stigma on mental illness. Such a negative stigma. In my eyes, I guess I had I want to say a dream team, because I think O.J. Simpson, he had a dream team. I had a dream team, and mine was my family. My family did everything for me. My mom searched high and low and found an answer, found somebody that could give it a name, because it didn't have a name. It was invisible, but it tortured me. I had a therapist that was not only knowledgeable, but she was just kind. She was kind and patient. And I think we underestimate sometimes what a kind act can do, especially people in that field. You know, they're so overwhelmed by the amount of people that they see. But a little bit of kindness would go a long way to each of their patients. You know, and last, I believe in God, and I believe God healed me, because what I was going through, I don't think any earthly thing I could have done, therapy, no therapy, medication, no medication, could have got me out of that at all. The other day I saw one of those Avon Walk commercials, and the girl said, "I kicked cancer's butt." It's like, that's cool. You know, I wish I could wear a shirt that says, you know, I kicked agoraphobia's butt. People would think, you know, something's wrong with me. But the way that a person with physical illness stands and celebrates after they've accomplished that beautiful goal of getting back to who they were, getting back to being healthy, you know, it's a beautiful thing. And for some reason, people with mental illness can't do that. They're embarrassed to do that. And I was embarrassed for a time. You know, it's not something that you want to stand up and say, I was going through this, because people do think, you know, because they're ill-informed, they think that's very weird. You know? But there comes a point where you just have to get over that. You just have to say, you know what, I'm proud. Because mental illness, unfortunately, it claims the lives of a lot of people, you know, through suicide. People can't handle what they're going through. They're lost. Families don't understand, and they can't offer that support. And that's a devastating thought. Very devastating. So, you know, it's a blessing for me to be here, to stand in front of you, to be out of my home, to be comfortable enough to talk in front of you, and, you know, to say I'm a survivor of mental illness, and I'm proud of it. So, yay.
Awesome.
So that concludes my presentation. Thank you. Tim said we'll do a question and answers after.
I think we'll do, if it's okay for folks, we'll do the presentations and then do question and answers for everybody afterwards, so that there's a chance to not like stew in their own nervousness.
Okay,
Because I know I
thank you
do have
guys.
questions for you for sure. So.
All right, thank you.
Great, thank you.